Hello, my name is Corey Langer. I'm the Director of Thoracic Oncology at the Abramson Cancer Center and Professor of Medicine at the University of Pennsylvania in Philadelphia. And doing the second part of my talk, tackling EGFR Exon 20 mutations, our current clinical challenges and new insights. I'd like to focus first on two specific tyrosine kinase inhibitors, Poziotinib and TAK-788, also known as Mobocertinib, each of which feature greater potency and much lower IC50s compared to second and third generation EGFR TKIs, Afatinib and Osimertinib. Poziotinib, in particular, features a quinazoline core and has 100-fold more potency compared to Osimertinib and 40-fold greater potency compared to afatinib when we look at resistant exon 20 cell lines featured on the right. Clinically, however, its efficacy has been disappointing. Initial reports suggested response rates of 20 to 30%, more recently under 20%. And the final confirmed objective response rate, 14.8%, shown in blue here on the waterfall plot presented by Dr. Lee at ASCO in 2020. Disease control rates are a lot higher. We see tumor shrinkage in the vast majority at 84%, but the trade-off is toxicity. In particular, those with exon 20 insertions in the near loop from the C helix seem to have somewhat higher response rates at 20 to 30%. This is shown in violet on the waterfall plot. However, toxicity is still the bête noire of Poziotinib. Grade 3 and higher rash and diarrhea in 25 to 30%, stomatitis and mucosal inflammation, fairly high rates of grade 1 and higher paronychia. If we look at long-term tolerance, dose interruptions in 87% of patients, dose reductions in 78%, and permanent discontinuation in 12%. These are results presented by Mark Szynski at ESMO in 2020, including patients not just with exon 20, but other EGFR mutations. Mobocertinib, like Poziotinib, has better IC50s compared to first, second, and third generation EGFR inhibitors, although perhaps not quite so potent as Poziotinib if you look at primary resistant mutations in exon 20. At this year's ESMO meeting in 2020, a cohort of 28 patients with exon 20 insertions were studied. All of whom received the targeted dose of 160 milligrams daily. If you look at the demographics, over 50% had received 3 or more prior anti-cancer regimens. Intriguingly, only 21% had undergone prior therapy with either an EGFR or HER2 inhibitor. Over 60% had received prior checkpoint inhibitors. The vast majority, as one would expect in this group, were never smokers, 61%. With respect to efficacy, response rate was a bit higher, 43%. Again, the vast majority of patients exhibiting some degree of benefit on the waterfall plot. Median duration of response was 13.9 months, with median progression-free survival of 7.3 months, looking a bit better than Poziotinib in this context. Again, the most common toxicities were those typical of EGFR inhibitors: diarrhea, nausea, rash, and to a lesser extent, upper GI side effects, vomiting and anorexia. This table was presented by Greg Riley at ESMO in 2020. Like Poziotinib, 32% of patients had grade 3 or higher diarrhea, though we see a lot less rash. Still, the incidence of grade 1 and 2 toxicity, including diminished appetite, nausea, and vomiting, xeroderma, etc., is a concern. Phase 3 trial in treatment-naive EGFR exon 20 mutant non-small cell is planned. Again, this focuses on those with resistance mutation. This trial will compare Mobocertinib to standard of care treatment upfront in therapy-naive patients. Standard of care in this case defined as pemetrexed at standard dose combined with either cisplatin or carboplatin. The trial targets 318 patients for accrual, making this the largest phase 3 to be conducted in exon 20 mutations. Primary endpoint is independently reviewed. Progression-free survival and stratifications are based on the presence or absence of CNS metastasis, as well as race and ethnicity. Other agents been looked at. Osimertinib is, of course, commercially available, indicated frontline for sensitizing mutations in exons 19 and 21. Compared to Poziotinib, its potency in exon 20 appears to be a bit less when we look at cell line viability when exposed to these agents. Zofia Piotrowska at ASCO in 2020 presented a phase 2 ECOG trial evaluating high-dose osimertinib, 160 milligrams daily in non-small cell with EGFR Exon 20 insertion. Confirmed response rate was modest at 24%, but the disease control rate exceeded 80%, with the median progression-free survival the best we've seen to date, 9.6 months, and median duration of response not yet reached. Again, small numbers, but a cooperative group, so truly real-world data. So even at double dose, 160 milligrams daily, we are observing far less grade 3 and 4 toxicity than we are seeing with either Poziotinib and to a lesser extent with Mobocertinib. The rates of diarrhea and rash are generally 10% or less. CLN-081 is also being assessed. Very preliminary data presented by Dr. Piotrowska at ESMO in 2020 showing clearly responses. Most common toxicities, again, rash, stomatitis, and dry skin. The RAIN trial, RAIN 701, was presented at ESMO by Steve Liu and colleagues assessing Tarloxotinib in the same setting, mixed cohort of patients with exon 20 insertion as well as HER2 activating mutations. Tarloxotinib, novel hypoxia-activated pan-HER inhibitor. It's actually a prodrug that embeds in but cannot permeate the cell membrane, ultimately fragments the cell-permeable Tarloxotinib E under hypoxic conditions, and this in turn is a potent pan-HER covalent tyrosine kinase inhibitor. The cartoon below demonstrates the breakdown into the active metabolite. Preliminary data, unfortunately, are very disappointing. We've seen no responses in this cohort. A few patients with stable disease, others having disease progression right off the bat. Toxicity, however, is manageable, at least with respect to the typical EGFR side effects, low rates of rash and diarrhea, but a third of patients having QT prolongation. One of the most exciting agents is bispecific antibody, JNJ372, now known as Amivantamab, which targets both EGFR and c-Met. These are data first presented by Jessica Bauman and colleagues at the 2019 ASCO meeting. Amivantamab alone or in combination with the oral TKI Lazertinib in patients with acquired EGFR resistance appeared active. In patients who had received third-generation tyrosine kinase inhibitor drug like Osimertinib, response rate here was 28%, with, again, majority of patients exhibiting at least some tumor regression. In combination with Lazertinib, response rate rose to 36%, and the percentage of patients with some degree of tumor shrinkage on the waterfall plot was even higher. These were separate cohorts of 58 and 45 patients, respectively. Toxicity really extends back to the target. We see EGFR-related toxicity, the vast majority grade 1 or 2, including rash, paronychia, stomatitis, pruritus, and diarrhea, fairly rare rates of grade 3 toxicity. We also see MET-related toxicity, hypoalbuminemia, peripheral edema, and others that may or may not be related to the targets, including nausea, anorexia, transaminitis, constipation, some dizziness and fatigue. By and large, most of these toxicities are mild or moderate. Amivantamab also has a unique toxicity, infusion-related reaction that typically occurs with the first dose. Over 60% of patients, it's generally limited to the first infusion, has led to split dosing with half dose, 350 milligrams, cycle 1, day 1, the remainder, cycle 1, day 2, and you can see on this slide that the incidence of infusion reactions diminishes with subsequent weekly cycles. By and large, these reactions are grade 1 or 2, and they're fairly typical of infusion-related reactions, chills, transient dyspnea, nausea, and flushing. They generally go away with steroids and antihistamines. Amivantamab has been looked at specifically in patients with EGFR exon 20 insertions, response rate of 36%, with the majority of patients exhibiting at least some degree of tumor shrinkage. Again, the toxicities here, as already mentioned. The next step for amivantamab is a phase 3 trial. The Papillon trial is open and accruing and comparing standard chemotherapy, in this case carboplatin and pemetrexed, versus the combination of chemotherapy with amivantamab. Note that we are avoiding immunotherapy here, and there are plans to look at the combination of lazertinib, oral TKI, with amivantamab in this population. So I have included cross-trial comparisons in exon 20. Response rates seem to be highest with mobocertinib, amivantamab. Toxicity clearly worse with poziotinib, to a lesser extent with mobocertinib, with osimertinib and amivantamab featuring substantially less grade 3 toxicity. Of all these agents, osimertinib is a confirmed CNS penetrant. We're really not sure about poziotinib and mobocertinib. More data are needed. Amivantamab, as a monoclonal, is not expected to have much CNS penetrance, but lazertinib in combination with it will most likely. We clearly have a long way to go in treating patients with primary resistant exon 20 EGFR mutations. Response rates from targeted therapy with other targets, at least most molecular targets in non-small cell, exceed 70%. They're reliable, they're often quite rapid. CNS penetrance is the expectation. We have TKIs that help reduce or eradicate the brain metastasis for EGFR, ALK, ROS1, NTRK, and RET. It's not clear if some of the newer agents targeting exon 20 will meet this expectation. And the toxicity profile of most commercially available TKIs is generally quite favorable. The rate of mucositis and diarrhea here is concerning. In conclusion, EGFR exon 20 mutations are associated with intrinsic resistance to first-generation TKIs. Double-dose osimertinib has modest activity with a median progression-free survival of 10 months or so, and it's available off-label, so it can be given without necessarily putting patients on a clinical trial. Mobocertinib or TAK-788 and amivantamab, the bispecific monoclonal targeting both EGFR and MET, have promising activity but are not yet FDA approved, at least as of December 2020. Our default option, at least in my clinic, is pemetrexed and carbo in combination with or without bevacizumab. In select patients with high tumor burden, rapidly progressive disease, I have resorted to the Empower 150 regimen, combination paclitaxel, carboplatin, bevacizumab, and atezolizumab. Some call it the kitchen sink. Clearly a bit of toxicity, but in younger patients is reasonably well tolerated, and I'll often split the paclitaxel dose, 100 per meter squared days 1 and 8 rather than 200 per meter squared day 1. I reserve osimertinib for second or third line, and obviously, if I can, I put patients on a clinical trial. So I thank you for your attention.